Welcome, everyone. We're going to go ahead and get started. So here we are at Quality of Life and Next Steps. We'll be hearing from Josh Mooney first, followed by Linda Manning with Using Mindfulness for Stress Management in Chronic Disease. And please welcome Josh Mooney.
All right, so thank you to the PFF for the invitation to speak. Thank you for everyone for attending. I think the special highlight of this conference is the involvement of patients and caregivers. So I'm going to be talking today on evaluation for lung transplant. Maybe I'll just start with, in the audience, are there patients that have undergone lung transplant? So a couple in the room. And then how many patients with pulmonary fibrosis? All right, a lot. And then caregivers? Great. So the objectives of my talk today is to understand what is lung transplant, whom lung transplant is for, when should a patient be evaluated or listed for lung transplant, and then really what should a patient expect with lung transplant. So I wanted to start just with a broad overview of transplant. Kind of the simplest definition of lung transplant is a surgical procedure where one or both of the diseased lungs is removed from a patient and replaced with a donor's healthy lungs. The first lung transplant procedure was in 1981. It was a heart-lung transplant. It performed at Stanford, followed a couple years later in Toronto. And over time, this therapy has increased in use and really has become an established therapy for patients with advanced lung disease, particularly pulmonary fibrosis. It's associated with prolonged survival and improved quality of life. This is a graph here showing lung transplant within the US and changes over time. Starting in 2004, you can see the overall number of lung transplants, as seen in this very top line here, has increased from just over 1,000 to now over 2,000, just over the past just over 10 years. This increase has predominantly been in the performance of bilateral lung transplants. I think what's really important, especially for you guys in the audience today, is what type of patients really have been undergoing lung transplantation over the last 10 years. And really, since the allocation system for lung transplant was changed in 2005, what we've seen is that patients with pulmonary fibrosis, as seen in the blue line here, has dramatically increased from just over 500 to now being the largest group, well over 1,000. And in conjunction with this rapid rise in the number of lung transplants performed for pulmonary fibrosis, what we see is that although the predominant age group continues to be those aged 50 to 64, those aged greater than 65 has significantly increased as well over time, as you can see here by the blue line. And I think that closely correlates with the patients that suffer from pulmonary fibrosis, often are of a little increased age. So what I wanted to spend some time on is for whom lung transplant is for and the timing surrounding lung transplant. And so when I see a patient in my clinic, and this can be in both my ILD clinic or in particularly lung transplant clinic, when I'm seeing someone and discussing their lung transplant candidacy, there's really three questions I ask of myself to think through as well as think through with the patient. And these three questions are: do you need a lung transplant? Are you an acceptable candidate for lung transplant? And if the answer to questions 1 and 2 are yes, then do you want lung transplant? So I'm going to focus the next bit of the talk around these three questions and kind of look at them in a little more detail. So do you need a lung transplant, and when should you undergo lung transplant. The important things that we consider as physicians is really trying to understand what type of lung disease you have, and are there other effective treatment options available, making sure that we've explored all medication options, non-medication therapies, and really what we're looking for is patients with that have been on appropriate treatments that still have end-stage lung disease with limited life expectancy. And the general guidelines suggest that those with a high risk of death, approximately 50% or greater within the next 2 to 3 years, these are the patients that we should really be considering for lung transplantation. So I think when I'm considering someone, in particularly with pulmonary fibrosis for lung transplant, one of the important things that I often look at is whether or not we fully understand what their diagnosis is. I think a correct diagnosis is important, not just for treatment, but also for prognosis and thinking about the timing of transplant. We know this is from a single center study looking at different types of pulmonary fibrosis, those with idiopathic pulmonary fibrosis or other types of connective tissue disease related pulmonary fibrosis or chronic hypersensitivity pneumonitis, is that the survival of these patients differ according to their underlying disease, with those with a solid top line representing IPF having the most significant mortality over time, with those with connective tissue or HP diseases tend to have a more slowly progressive disease. So I think correct diagnosis is important in when considering timing of transplant, and then also for ensuring that they've received appropriate medical and supportive therapies. One of the difficulties we have with pulmonary fibrosis, and this includes idiopathic pulmonary fibrosis, and I think is applicable to other types of pulmonary fibrosis as well, is that they can have a fairly unpredictable disease course. And you may have experienced this yourself or seen it in friends or loved ones, is that we know from experience that some patients have a more rapid onset of disease, where other patients have a more slowly progressive form of disease, and that this course of progression can change over time, and that there's these periods with acute declines as marked by these stars here called acute exacerbations, where patients can be relatively stable and have acute drops in their lung function and symptoms. And therefore, I think one of the important takeaways, both for patients and for providers, is that given the unpredictable nature of pulmonary fibrosis, that early referral and evaluation for lung transplant is important to ensure that options are available. There are some clinical tools that we can use to assess kind of risk of disease progression, risk of death, and also to help with assessment of transplant timing. This is a tool that you may have heard in other settings called the GAP score, which is applicable to IPF and has been evaluated some in other forms of pulmonary fibrosis as well. But it's a simple tool looking at very clinically available criteria such as gender, age, and your lung function tests. And based on those values, we can come up with a score and kind of a stage of the disease. And the stage of the disease, I think, is helpful because those with stage 1 disease tend to have fairly normal or mild lung function impairment, and oftentimes in those settings we can consider evaluation for lung transplant, but often those patients are too early for listing for transplant. Those with stage 2 are those patients that are starting to near timing for lung transplant listing, and those with stage 3 disease are those patients that are almost uniformly within the window for lung transplantation if they're otherwise acceptable candidates. So this is one of the tools that I use and other clinicians use to help assess for timing for transplant. When kind of looking at the data that I just showed, there's been some general recommendations about when patients should be referred for lung transplant evaluation. This is not necessarily going on the list for transplant, but just to be evaluated and seen by a lung transplant center. And the number one criteria, which I think comes to a surprise of many, is that the recommendations are that at the time of an IPF or fibrotic NSIP diagnosis, regardless of your severity of illness, lung transplant evaluation should be considered. I think in some centers, and particularly ours, where there's integration between our ILD and transplant teams, this can be delayed slightly, but certainly in patients that are out in the community, I think it's very appropriate at the time of diagnosis to be for this to be discussed and referral made if otherwise appropriate. Certainly, patients that have abnormal lung function, if they develop an oxygen requirement, even if it's just with exertion, and if they have progression of their disease as characterized by increased oxygen need, increased symptoms of shortness of breath, or a decline in their lung function numbers after appropriate therapy. These are patients that under general guidelines should be referred for transplant evaluation. I'll get into a little, in a few slides, the differences between referral and transplant and kind of the timeline of lung transplant evaluation, but after referral, the next decision becomes when do we actually list you or put you on what we call the active wait list for lung transplant. And the things that we typically look at as pulmonologists in this setting is we look for evidence of disease progression or changes in your lung function numbers over time. And the reason we do this is that we know from clinical trials and other data that changes in lung function, changes in your forced vital capacity and your diffusion capacity, or in your ability to perform the 6-minute walk test closely correlates with mortality. So what we're looking for is patients that are demonstrating disease progression. Sometimes we see patients that have very advanced disease at initial evaluation that are needing continuous oxygen or have low lung function numbers, and oftentimes in these settings we'll consider listing. I think that with both of these slides, I do think that the decision for listing in particular is somewhat dependent on centers and the expected wait time and other things. So I think this is these are general guidelines, but in no way kind of the final say. So the second question that comes up is, are you an acceptable candidate for lung transplant? And what we're looking at here is basically two questions about, do you have a high likelihood of surviving the transplant surgery, which is one of the largest and most intensive surgeries we do in medicine. And if you make it through the surgery, do you have a high chance of long-term survival? Meaning, just from a general medical perspective, would you be expected to have a good chance of long-term survival? And so to try to answer these questions, a number of criteria have been proposed as absolute or relative contraindications for lung transplant. This is from a consensus paper by the International Society for Heart and Lung Transplantation. These are supported, I think, by varying degrees of evidence, and particularly within the relative contraindications, there's tremendous variation by program. So this is meant, again, just to be more of a general overview and is not definitive. Absolute contraindications are typically the presence of a recent malignancy, particularly within the last 3 to 5 years. Untreatable other organ dysfunction, those with significant heart, liver, or kidney disease. Those with obesity characterized by a body mass index greater than 35. And then those with history of poor or limited functional status with poor rehab potential, adherence issues, past substance use issues. These are general absolute contraindications. The relative contraindications, the guidelines do suggest age greater than 65, but this varies tremendously by program. I know at our center we go into the 70s, and many centers across the country will go into ages 70. Body mass index in the range of obesity with a BMI of 30 to 35. There's some varying criteria by programs. Patients that are on advanced life support, either on a ventilator or on other machines to support their breathing, carry increased risk. And recently there's been an increase or demonstrating acceptable outcomes with patients with HIV or other sorts of infectious diseases. And so these have changed from historic absolute contraindications to relative contraindications. So thinking through our last question is that if you're in need of a lung transplant and if you're an acceptable candidate, do you want a lung transplant? And this is really, I think, a patient-centered question, and understanding the risks and benefits of the surgery and the commitment required to have a good outcome with lung transplant. And what I really encourage patients is to be an informed consumer of transplant, and I think really to have education about the transplant process. And so that's what I hope to do in the next portion of my talk, is to really talk about what should one expect with lung transplant. And we'll go through both outcomes as well as the kind of procedure and recovery aspects of transplant. So this is my kind of busy schematic of what a typical lung transplant timeline is, and I really want to focus on kind of 4 periods of the lung transplant evaluation. And this is really the evaluation where you're seen at a center and the decision is made about whether to pursue active listing or whether to wait, or whether you are unfortunately not a candidate. This period where you're on the wait list, this period where you're in the hospital recovering, and then what life looks like in the post-transplant period. So I'll walk through each of these 4 areas. In terms of the transplant evaluation, so what happens is that your pulmonologist or your pulmonary fibrosis physician refers you to a transplant center. There's a lot of things going on behind the scene during that process. We're receiving authorizations from your insurance company for transplant. We're reviewing your medical history. And oftentimes, if everything looks good, we're inviting you to come to our center for a full evaluation for transplant. And this involves usually several days. It can be up to a week of extensive testing, as well as education and visit with transplant pulmonologists and surgeons. The evaluation testing that one undergoes, this is a very busy slide, but I just wanted to highlight that there's a number of things that are done. We're looking at the severity of your lung disease, again, to assess the timing and readiness for transplant. And then we're looking at how well your other organs work, how well your heart, your kidneys, your liver, etc. works. We're looking for presence of any undiagnosed malignancy. And so there's a number of testing that you go through. There's also evaluation for your nutritional status. You meet with a social worker and undergo a psychosocial evaluation. Caregivers receive education. So very time-intensive process. Once you're seen and undergo the evaluation and you're seen in clinic, typical programs have meetings where they discuss all potential candidates for lung transplant. It's usually a decision made by the transplant team and not a sole member about whether a patient should be listed for transplant, whether a patient perhaps should be deferred, perhaps they're too well or further testing is needed to determine whether or not transplant could be a benefit to them. And in some cases, unfortunately, patients are declined if we feel like you can't receive an adequate benefit from transplant. So if the decision is made to move forward with transplant, patients are put on a transplant wait list. And I think patients have a lot of questions usually about what happens during this process. It can be a stressful time for patients. And so patients are put on a national wait list. They're assigned a score that ranges 0 to 100, and this is based on their severity of their illness. The expected time on the transplant wait list really varies by where you live and how sick you are. I put some general numbers on there for pulmonary fibrosis patients. The average wait list, or the median wait list time, is about 2.5 months. But this can vary across the country. Overall, about 25% or so of patients are transplanted within a month, and 65% of patients are within 1 year. Typically, pulmonary fibrosis patients receive a little bit more priority or benefit due to the typical natural course of their disease. A lot of questions come up about how one receives a lung, or how is it determined who gets a lung. So when a donor becomes available, what happens is that a donor is assigned to a candidate within one of these kind of arbitrary geographic areas. And so there's a number of centers, as indicated on this map here, within what we call donor service areas, or OPOs. And donors are matched with candidates within those areas. And they're matched by blood type as well as by their lung allocation score, that priority score. Patients with once matched are reviewed by centers to make sure that they're a correct match as far as height and size. And if there's no local matches or matches within those donor service areas, then their matches are looked for more broadly. So this is a general kind of simple schematic of what happens. Well, on the wait list, we never know, of course, when transplant can happen. So candidates have to be readily available and can reach transplant centers within an acceptable period of time. Typically, this is 4 or 6 hours. They're updated frequently as far as their medical condition to make sure that they maintain adequate transplant candidacy, as well as we're reflecting their medical condition or their need for transplant. So once we receive an offer for lung transplant and a match is made, a candidate is called into the hospital. And I always discuss with patients, until the surgery happens, it's not a for sure thing. There's always last-minute cancellations based on whether the donor lungs are suitable or not. Other questions that patients typically have is, what kind of surgery will I have? And this varies really by center and the surgeons at the center. At our center, majority of patients receive what we call a median sternotomy, which is surgery through the breastbone. Other centers use a clamshell technique. And other patients that just receive single lungs receive a more thoracotomy. The typical surgery will take several hours. And post-transplant, patients recover in an intensive care unit. In the intensive care unit, we wait for patients to wake up and demonstrate that they can breathe adequately on their own. When this is demonstrated, they're disconnected from the breathing machine. There's a number of IV medications that are often needed initially. There's chest tubes in place to help drain fluid from around the lung. And patients begin to receive antibiotics as well as anti-rejection medications to prevent rejection and infection. So a lot happens in those early days. Typically, a course in the intensive care unit may be 3 to 5 days. And their transplant hospital stay, if everything goes well, is on average about 2 weeks across the country. Once patients get out of the acute phase and get out of the ICU, there's a lot of focus on rehab, and recovery from surgery, and this is particularly important for patients with pulmonary fibrosis. There's a tremendous amount of education, both by nurses, pharmacists, and other support staff about the appropriate use of medications and other education. So our patients, by the time that they leave the hospital, are very familiar with what medications they should be taking and what to look for outside of the hospital. Some common things that come up after transplant, there's a condition called primary graft dysfunction, which is basically fluid accumulation in the lungs, similar to pulmonary edema, and this occurs in anywhere from 25%, 30% of patients after transplant. There's also, of course, bleeding issues that can occur, fluid accumulation around the lungs, problems with blood vessel or airway connections, and kidney dysfunction. These are some of the more common things that we see early on within the hospital setting. Once you leave the hospital, the case at many centers is that they ask you to live close by the hospital, and this is due to problems that more often frequently arise within the first couple of months after transplant, as well as a need to frequently be evaluated by the transplant team and perhaps have further testing. The highest risk for complications occur over the first couple of months, and so regular blood work, chest x-ray, and even breathing tests are done initially and over time. Patients begin a pulmonary rehab program, and at most centers, patients undergo a bronchoscopy procedure to evaluate for infection and rejection as shown there. There's a number of medications that people take after transplant. I've listed the 3 most common ones across the US that are used: tacrolimus, mycophenolate mofetil, and prednisone. I listed some of the associated side effects with these medications, some of which you may be familiar with. But these are, of course, things that we monitor for and control for with other medications, diabetes medications, high blood pressure medications, etc. Things that often come up in the post-transplant setting is acute rejection. Can occur and occurs in about a third or more of patients over the first year after transplant. This is diagnosed by bronchoscopy procedures and a review of those, the pathology under a microscope. There's also another type of rejection called antibody-mediated rejection that is diagnosed largely by blood tests. So there's a lot of monitoring for this over the first year. Unfortunately, one of the problems with lung transplant is the development of what we call chronic lung allograft dysfunction or chronic rejection. The most common cause of this is what we call bronchiolitis obliterans syndrome, and this is progressive scarring of the small airways that leads to airway obstruction. It's the most common cause of death in patients post-lung transplant. And as you can see by this busy figure here is that at 5 years, approximately 50% of patients develop this syndrome. When you get out to 10 years post-transplant, about 25% of patients, 75% of patients have bronchiolitis obliterans syndrome. So very common condition. I always get questions about post-lung transplant survival. So this is just general survival in the US, and it's broken down by age categories as well as disease. General survival is about 85% at 1 year and 55% at 5 years. This is slightly lower for those that are transplanted at an older age, So those at age 65 tend to have a little lower survival, as indicated here, over time. And those with pulmonary fibrosis, which is indicated by the blue line over here, again, tends to be a little bit lower than patients that are overall younger. So this is data, I think this is 2013 to 2015 or so. Yeah. And then lastly, one of the important things that I discuss with patients is that we do lung transplant not just to improve longevity or survival, but also to improve quality of life. And there's good data that transplant does that. Our goal is to return patients to a relatively normal life. And there's been a number of studies using various instruments that measure quality of life or activities of daily living. And this have all largely showed benefits post-lung transplant. And this is really somewhat irrespective of disease and age. So in summary, we reviewed what is lung transplant, whom lung transplant is for, when a patient should be evaluated and listed, and what to expect with lung transplant. And I guess if there's any time, I'm happy to take some questions.
Mike?
Go ahead with the mic.
My question is the opioid epidemic. I understand that that has provided an increase in the source of lungs. Can you comment on that?
Yeah, so unfortunately, we have seen it not just across lungs, but all of solid organ transplant, and really an increase in, I think, transplants over time. And I think that's been, unfortunately, partially fueled by unfortunate deaths from opioid overdoses. Oh, he was just commenting on that with the opiate epidemic that he's read about increased deaths and organ transplant.
Does that mean you can't use the lungs?
No, they're generally usable. I think beyond just that, I think as a lung transplant community and solid organ in general, we've over time understood more clearly which lungs can be used, and I think our criteria for which lungs can be used have become broader, and we've really noticed really good successful outcomes with lungs that perhaps we wouldn't have used 5 years ago.
If you have to move out of an area, like to go to a place, say like Cleveland, because they're going to do a lung transplant on an older patient, how long would you have to stay there after the transplant in order to kind of be in their program? Can you transfer back to where you lived before?
Yeah, so I can't speak for every program. There's some institutional specific rules. I think for us at Stanford, we typically require patients to live in an area for 3 months. And they're for sure 2 months, generally 3 months. And after that, they typically can go home, but there will be usually monthly or near monthly follow-up visits.
Could you comment, please, about how you determine whether it's a single or double lung transplant? And also, I've heard references to like a fresh lung versus one that's been sanitized. I'll use that word. And how you determine that?
Yeah, so the most common transplants are bilateral lung transplants, as shown in one of the earlier slides. There's, I think, still ongoing debate and a varying opinion probably amongst centers about when to use bilateral versus single lung transplant. There's particular settings where we can only use bilateral lung transplants. So in some non-pulmonary fibrosis diseases, like cystic fibrosis or pulmonary hypertension, they have to have bilateral lung transplants. If there's a significant amount of pulmonary hypertension, which we often see sometimes in patients with pulmonary fibrosis, in that setting, generally we can't use single lungs, and they will have to pursue bilateral lung transplants. One of the more commonly used criteria is single lung transplants can usually be done without going on a heart-lung bypass machine, and the recovery period is usually quicker after single lung transplants. So in patients with more advanced age, sometimes our general inclination is to pursue single lung transplants just because their ability to survive the surgery and have a good outcome seems to be better. But there's varying opinion on that. I think to your other question, I think what you're alluding to is there's been advancements of machines that we can take lungs from donors, put them on a machine that helps ventilate the lungs, and we can evaluate them further. Sometimes we can even give them treatments. Those are all in clinical trials right now, largely in studying, and so we think it's hopefully going to be a great option in the future to help utilize more donor lungs. But I think that's what you're alluding to.
Great, and we have time for one more question.
Are there any indications on the people who survive longer with a lung transplant? Does fibrosis develop again in the transplanted lung?
Yeah, generally no. I think there's a different type of fibrosis. It's the chronic rejection can either be a fibrosis around the airways, leading to airway obstruction, and that's the most common thing that we've seen, and that's in pulmonary fibrosis and non-pulmonary fibrosis patients. There's another type of chronic rejection that looks more similar to pulmonary fibrosis, but we think is different from it, and it all seems to be kind of an immune response where the body's not accepting the new organ. But generally, no. In connective tissue diseases in general, we don't see reoccurrences of the disease. But there's been some isolated case reports, both in connective tissue and hypersensitivity pneumonitis of reoccurrences.
Wonderful. Thank you so much, Josh.